sessions and lectures. Dr. Santosh Ravindran, and I call him the people's dentist, the dentist's dentist, because if anybody needs anything, and I say he is indeed the go-to man. Graduate of Government Dental College and Hospital, Mumbai, was a very active student. He ensured he brought about significant changes in the way the students went about their curriculum and their student tenure, both in the hostel and in the college. He silently started his practice, and in the recent 10 years or so, he has accumulated so much experience and goodwill from his practice. He planned to share his experiences in various aspects, be it the choice of restorative materials, be it medication, prescription practice, the way you run your practice ethically, training the youngsters. He is responsible and holds the unique record of probably the only dentist in the country to have addressed dentists from tier 3, tier 4 and towns beyond in our country. Ladies and gentlemen, without much ado, presenting the CIPLA oration today. As you recall, CIPLA is the presenting partner of E-Famdent, and he is bringing to you a very, very commonly discussed, debated, dissected topic, managing infections in clinical practice. Over to you, Santosh.
Thank you, Kumar. And pleased to do this for E-Famdent. We have done a lot of different topics at different E-Famdent venues. And this is the first time that I'm doing a topic sitting at in my living room. So I would like to speak to you today regarding managing infections in clinical practice. Now, we have been doing this for years together, but now the scene is a little different because we have come across an unprecedented guest, that is the COVID virus, the coronavirus, the SARS-CoV-2 virus. We know that it has created a lot of mess all over the world. People are just struggling how to manage this virus because nobody has any data about this. Researchers are working 24 hours trying to get a vaccine. But what we need to understand is that this virus is here to stay. It's not going away anywhere so soon. So we need to get back to our practices, but we need to be careful. So what does that mean? What is the future? First and foremost, we need to adapt to the new normal as early as possible. How do we do that? We have to implement all the new equipments, instruments, and materials that have been recommended by experts so as to be safe and keep everyone safe around you. That is your patients, your staff, your neighbors, your families. We need to learn and implement these protocols in your practice because a lot of things are different now. And that is the new normal. We have to understand that that is the new normal. We have to learn and adapt to changes in managing infections in clinical practice. Now, this is the topic for today. So without talking much about the protocols which we need to follow, I will talk to you about how to manage infections in clinical practice in the current scenario. If we look at the most common infections tackled in a dental practice, what are they? Endodontic related, oral surgery related, and periodontal therapy. Like Dr. Ajay Bajaj just said, in endodontics, technically, you do not need antibiotics if you are not going to force any of the debris periapically. Now, that is something that Ajay can do. That is something that few people can do, but that is not something that everybody can do. So a lot of people still take the support of antibiotics even while doing endodontics. Theoretically, you need not use, but practically a lot of people are using. So considering the ground reality, considering what a majority of people are doing, we'll talk about endodontics also. Now, this is the scene now where dentists do not want to treat active cases, in the sense they do not want to do elective treatment. So if you want to postpone treatment, is it possible? Yes, it is possible, but for a certain period of time. You can just buy time. What we were doing in April and May, when we were all sitting home, is basically antibiotic therapy along with the anti-inflammatory, which we used to do. And that achieves the objective. It achieves the objective quite often. However, the prescriptions that we need to give now in the COVID era is something different from what we used to do earlier. That's what we are going to talk about today. Now, most of the patients who come to us with cavities, and that is basically restorative dentistry. In restorative dentistry, earlier, it was just the drill and fill stuff that people were doing. But now we need to explore other options other than root canal therapy if you want to avoid root canal. In this presentation, I will be sharing with you different products from different companies. So if you are keen on trying to achieve all these things, maybe you can take screenshots or just scribble the names of the products or take pictures or whatever. Here on, the products will start coming in one by one for every step that I'm trying to explain to you. So what are the options in restorative dentistry? That is ART, atraumatic restorative technique. Now, this is something that everybody knew about, but it was not implemented because it was not needed. It was just done in places like Africa or some interior parts where it started in Africa primarily because they did not have electricity, they did not have drills, they did not have equipment. So what is ART? It is an evidence-based, minimally invasive operative intervention where hand instruments alone are used to prepare a cavity atraumatically, and the cavity is subsequently restored with a self-adhesive, bulk fill, high-strength, fluoride-releasing glass ionomer. Please understand that when this was started, they would fill zinc oxide eugenol. It graduated to zinc phosphate, and then it came to glass ionomer. Those were glass ionomers which we were using much earlier, but now we have a glass ionomer which adheres to all these things that I have mentioned here. Self-adhesive, bulk fill, high-strength, fluoride-releasing glass ionomer. If you want to use that, it's called a hybrid glass ionomer. It comes in the brand name called Equia Fort. Now, when the patient comes to you with a cavity and you want to do this, but you are not equipped to do only with a hand instrument, you want to do it with a rotary instrument. That is what is called a newer modifications of ART, wherein there is a use of slow speed micromotor, use of electric motors, or you can arrest the caries using SDF, that is silver diamine fluoride. That technique is called silver modified atraumatic restorative treatment, that is SMART. Application of pulp devitalizers, that is, you know that the pulp is exposed, but you do not want to do a root canal, you can actually devitalize the pulp and by a period of time, maybe a couple of months. Or if you're doing excavation and then you encounter a pinpoint exposure, you can do a direct pulp capping, but that is not done with calcium hydroxide, it is done with bioceramics. Now I'll show you the product for each and every point that I mentioned here, all the 5 points which are there here. These are the motors, electric motor with an electric handpiece. Comes from NSK, which everybody knows about, but not the regular NSK handpieces. The regular NSK or any other aerotor will project air and water at high speed. Here, there is only water. Some people have a doubt whether it will give you the same efficiency of cutting efficiency. It does, because you can adjust the speed up to 2 lakh RPM. It has two models, NLX and NLZ. Why I've shown you NLX is because NLX is the electric motor that I use in my practice. This is called ESDF. ESDF, which is a brand. There are many brands in the market. There is Fagamine, which comes from Argentina. There is Caries Arrest, which comes from Korea. And there is ESDF, which is a made in India product. And you can just go online and place your order. What you need to understand is that if there is a carious lesion and no exposure, this can be used only if there is no pulp exposure. So if there is caries, you do not want to excavate the caries, you do not want to use an electric motor or do anything, but you want to stop the caries, you can stop the caries by putting ESDF. How do you apply it? You take it on a small pellet of cotton, put it into the carious lesion and agitate it for about 60 seconds. After 60 seconds, you wipe it dry and you wash it off and you cover it with a glass ionomer or with a non-eugenol temporary. The only thing what happens with this is that it discolors that entire surface. It becomes black in color. So you need to inform the patient in advance that your tooth will become black in color wherever I apply this. If it touches anywhere else by mistake on a soft tissue, that discoloration will go away within 15 days. Suppose the pulp is exposed, then you cannot put silver diamond fluoride. You have to devitalize the pulp with the help of any of these pulp devitalizers. That is a pulp X that comes from Prevest, or depulpin that comes from Voco. There is something called Costi Nerf that comes from Septodont, but that is currently not available in our country. And in case you are excavating and you accidentally create an exposure, you will seal it with a biodentine. Dr. Ajay Bajaj before me spoke about BioRoot RCS, which is a sealer, a root canal sealer, which is derived from biodentine. They are both primarily bioceramics. Like Dr. Bajaj said, bioceramics are the only materials which do not contract on setting. They do not contract on setting, they only expand on setting. So because of that, it will seal the exposure completely. It is bacteriostatic in nature, plus it stimulates the formation of odontoblasts. So it's the ideal direct or indirect pulp capping agent. But what happens if a patient comes to you like this, holding ice to the external surface of the face? This is a clear indication that the patient is suffering from acute gaseous pulpitis. So when there is a gaseous pulpitis, the gases are unable to escape from the root canal system. And because the gases are expanding, the patient gets pain. By applying ice, the gases will contract and the patient gets a relief. This means that you have to do something. This just cannot be controlled with any antibiotic or any anti-inflammatory. In this case, you have to take the patient onto the chair and you have to inject and you have to open the chamber. When you inject, you need to understand that now in this COVID era or post-COVID era, we have to upgrade from vials. You just cannot use vials. It has to be safe, so you use only cartridges. These are two different molecules. The one on your left that you see here, that is Lignospan Special, that is lidocaine. And if you want the anesthesia to be more profound, you can use Articaine that comes under the brand name called Septanest. So in Articaine, the profoundness of anesthesia is greater, the onset of action is faster, and you can use this for all procedures. What are the antibiotics that we have been using till now? Amoxicillin, yes. A lot of people use amoxicillin, still use amoxicillin. Amoxicillin and cloxacillin combination is what we need to use in endodontics if you want to give an antibiotic. Amoxicillin and potassium clavulanate, this is something that a lot of people were using, which at that point in time was not required. But at this point of time, this is an antibiotic which has gained tremendous significance, tremendous importance. Cefixime, ciprofloxacin, ofloxacin, and cefadroxil. Cefadroxil primarily works best on soft tissues. So a lot of people used to use that for periodontal therapy. But now we will see what we have to use. What are the antimicrobials that we were using? We were using metronidazole and ornidazole, and we continue to use the same. And what are the anti-inflammatories? Ibuprofen, diclofenac, aceclofenac, ketorolac, piroxicum, tramadol, and mefenamic acid. Now, there are certain researchers who have actually said that ibuprofen and diclofenac should not be given now when the virus is doing the rounds. Even aceclofenac is not to be given. There are certain other researchers who have come up with papers which say that it is absolutely safe to give. But my take on this is that if there are some researchers who have said that there is a problem of giving ibuprofen or diclo or aceclo during these days, then maybe just to be on the safer side, we do not give. What do we give? We can safely give ketorolac, or you can give piroxicum. Now in endodontics, like I said before, ideally no medications. Ideally no medications. But otherwise, earlier, pre-COVID, we were using Amox plus Clox combination with ibuprofen. Or if it is a badly infected case where there is pus coming out, we were using Amox plus Clox with metronidazole and ibuprofen. Sometimes if we feel that it is completely gram negative and there is a swelling, we would give an Oflox ornidazole combination with ibuprofen. But what we are doing now is if an antibiotic needs to be given, we give an amoxicillin with potassium clavulonate. If required, we add an antimicrobial to it, which will be ornidazole 500 milligram with ketorolac or piroxicum as the anti-inflammatory. What happens in oral surgery? In oral surgery also, there are a lot of good oral surgeons who believe that only ibuprofen if required, nothing else. But to be on the safer side, people were giving amoxicillin with ibuprofen, which was the most common prescription back then. Swelling patient, amoxicillin with metronidazole and ibuprofen as a painkiller. But what are we doing now? We are giving amoxicillin with potassium clavulonate, and a painkiller will be same like in endo, ketorolac or piroxicum. If there is a huge swelling, we will add an antimicrobial, which here again is ornidazole 500 milligram. Why am I stressing on ornidazole 500 milligrams? Is because the patient will remember to take it along with the amoxicillin potassium clavulonate combination. There are some people who suggest that you can take it thrice a day, but even twice a day is more than enough. So the clavulonic acid combination is taken after breakfast and after dinner, keeping a 12-hourly gap, and along with it, ornidazole if required, and along with it, the anti-inflammatory if required. In periodontology, good periodontists like Dr. Kumar Swami, they never require an antibiotic. They just give ibuprofen if required, one ibuprofen before surgery, one after surgery, and after that if required. Some of the periodontists prefer that soft tissue. You can give cefadroxil along with ibuprofen. Some were giving amoxicillin along with ibuprofen, and some were giving amoxicillin with potassium clavulonate with ibuprofen. Now we give amoxicillin with potassium clavulonate with ornidazole as an option and ketorolac piroxicum if required. So you would understand that the antibiotic and anti-inflammatory and antimicrobial therapy for endodontics, periodontology, and oral surgery now in the COVID era, and maybe for some more time, is going to be this. Only because we do not want to take a chance where something may go wrong. We all have read enough about this virus and how it behaves. We know that it will enter a person's body and symptoms are not seen for 12 to 14 days. So this patient is till then an asymptomatic carrier. And by chance, if this patient is on the chair, we do not want to take a chance. That is the reason why we are stressing on this so much. Now, this is one of the most commonly used amoxicillin potassium clavulonate combination, Novomox CV, made by Cipla, which is a reputed company. I know that there are a lot of companies who make this combination because obviously the pharma companies want to build their business out of this, which is the most potent antibiotic as of now. But we should also understand that it is always better to go with a reputed company where if it is written 500 milligrams of amoxicillin, there has to be somewhere between 480 to 500 milligrams. The pharma companies, there is an authority based out of Hyderabad which actually monitors this content of different companies. In fact, what they do is they pick up these medicines, not from the company or from the factories. They pick it up randomly from different cities, from different chemists, and they study it in Hyderabad, and they find out whether the claim of 500 milligram is true or not. And unfortunately, most of the companies fail to come. In fact, there have been some companies where it is written 500 milligrams, but the drug content was hardly 250 or 270 milligrams. So which are the companies which were giving this? Cipla was there, of course, and there were a couple of more like Reddy's Laboratory and Ranbaxy and Abbott Laboratories. But many of the others were falling short of the target by a significant figure. So in Novomox CV 625, there are different combinations for different body weights. It's all there online, which you can study. But just to let you know what are the different strengths which are there, you have something which is half strength, which is a 375 milligrams, where the content of amoxicillin will be 250 milligrams. So if it's a pediatric patient, you could go ahead with that, or anybody below 35 kilograms of weight, you can go ahead with a 375 milligram Novamox CV. Now, if it's a child who does not take tablets too well, then you can give either the drops which are there, which is given only for infants. Obviously, the infants are not going to come to a dentist, but this is just for your information. And then you have got Novamox CV dry syrup, and you have got Novamox Fort. Now, this is somewhere in between, which is not a pediatric and not an adult dose. As you can see, it is a 457 milligrams. So if it's like a 14-year-old child to a 10 to 14-year-old child who is slightly overweight, so it's still a child, but the child is weighing say 50 kilograms, then the CV dry syrup may not work. So you would have to go in with a Novamox CV Fort syrup. Novamox CV Fort syrup. Now, these are different combinations which were there. You can have a look again. You have got Novamox CV 625, which is for adult dose. Adult dose is above 35 kilograms. Some people say above 40 kilograms, but that's the adult dose. You've got a pediatric dose of 375 milligrams, and you have got a range of pediatric options, that is drops, dry syrup, and Fort syrup. Now, these are all amoxicillin with potassium clavulonate, which is relatively safe and the most effective antibiotic in today's scenario. So what are the anti-inflammatories that you have got? We recommend only piroxicum and ketorolac. We need to understand that the pyrox is a little more effective in restricting the pain, but obviously it's not as good as an ibuprofen or a diclofenac, but it is relatively very effective and very safe. The studies which were actually ruling out ibuprofen and diclofenac was saying that the patient is asymptomatic, and if the virus has already gone into the respiratory system, we are already aware that the ibuprofen can give you bronchospasm. So that's why they were recommending not to use. Of course, the CDC has given a green signal that you can go ahead and use an ibuprofen, which was done about a month and a half back. But personally, I have still not started prescribing ibuprofen, just out of the fear that just in case he is an asymptomatic carrier, we do not want to aggravate the situation by giving a strong anti-inflammatory. Now, COVID infection, what are the safety measures to be taken? All standard safety measures to be implemented in clinical practice to prevent the spread of virus in or from your practice. Basically, all these are standard safety precautions which have been discussed so many times over webinars over the last 2 months, wherein we know what has to be done. Now, a lot of people, I myself have done a couple of webinars on this. So a lot of times people connect to me directly asking me whether we should buy the UV light or whether we should buy the fogging machine. I have had detailed discussions with a lot of people who have done a lot of research in this, including Dr. Arunachalam, Dr. Shankar Iyer, and Dr. Udatta Kher, and all of them were of the opinion that there is no evidence to substantiate the use of a fogging machine or of the UV lights. So in our clinic, we have not implemented both these, but we obviously have the HEPA and the negative ion filter, which is there, and all the other safety measures which are there. But what we need to understand is that how much ever we try to hide from the virus, it is most likely to enter a majority of the population. And that is why it is extremely important that you build your immunity with proper nutrition and nutritional substitutes. Try to take a multivitamin which has a zinc content in it every day. Try to have cod liver oil capsules. Try to have the CADA, which has been promoted by our beloved Prime Minister in his speech on the 14th of April. Back on 14th of April, he had said that you should have CADA every day. And of course, you do your yoga and pranayama and you should be good. Let the virus enter in and it will not be able to affect you if your immunity is strong. Now, is the future uncertain? Now, from this future uncertain, that is 1990 to 2000, we had the HIV pandemic. Then it was not a pandemic, say it is an epidemic. 2009 and 2000 up to 20 maybe, but primarily 2009 to 2010, the H1N1 had wreaked havoc in our lives. 2018-19, we had the Nipah virus, and now 2019 onwards, we are seeing something called a COVID pandemic, which is totally unprecedented, unimaginable, the extent to which this virus has spread. But we need to understand that we have to continue with our lives. We have to continue with our practices. So we have to overcome, we have overcome challenges earlier, and we will overcome this too. This too shall pass. And with this message, I would like to thank all of you for sharing your time and allowing me to share screen space with all you guys. That's my mobile number, which is also the WhatsApp number and the email ID. So in case you have queries, obviously now Dr. Kumarswamy will be coming onto the screen and sharing the questions with me, whatever has come to him in the chat box. But even after that, if you see me, I mean, in the recorded version and you have doubts, you can go ahead and either mail me or WhatsApp me, and I'll be more than happy to answer your queries. Thank you so much. Signing off, Santosh Ravindran.
Thank you. Thank you, Santosh. Now, the commonest fear, if I may use the word, that we clinicians have is allergic reactions. I'm sure you addressed it briefly, but can you sort of dig deep in? Somebody wants to know, in our Indian scenario, the gastric irritation is the commonest.
Yep.
So what molecule would you
for gastric irritation, like normally a lot of people do not take too well to the combination of amoxicillin with potassium clavulonate. So we put them onto pantoprazole with domperidone combination. Commonly, we prescribe a pan D to be taken on empty stomach as soon as they wake up, so that they are able to tolerate this well. And usually, we do not see much of allergic reactions with these drugs. But in case we do encounter, then fexofenadine is a good drug of choice. We have a lot of anti-allergics like cetirizine and all this, but fexofenadine, that is Allegra 180, is extremely effective in correcting such type of reactions if there are any.
And if one were to talk about the efficacy of a single molecule as opposed to a combination, being a periodontist, obviously, I'm talking about the presence of anaerobic infections. And would you prefer to have a single molecule antibiotic and add metronidazole or etranidazole or anything like that, or a combination?
See, what we were preferring to do, like even in perio, we would put the patient onto an antimicrobial along with the antibiotic. Now we have a lot of combinations, like you get the O2, which is an ofloxacin with an ornidazole. In fact, there is a combination where there is a drug which has cefixime 200 milligrams, ofloxacin 200 milligrams, and ornidazole 500 milligrams. So we do have combinations. The only thing is what we are trying to tell is that till this pandemic is sort of over, maybe in the next 4 to 6 months, till then we try to stick to a combination of amox with clavulanic acid.
And in your experience, the allergic reactions, if at all, to any of these antibiotic molecules, like by way of a rash, or is it always mild to expect, or you also have some severe reactions to it?
Usually it is very mild. Some people do not take to ketorolac too well. And those people we'll ask them to discontinue ketorolac and go on to pyroxicam. And we give them just one tablet of fexofenadine, that is Allegra 180, is sufficient to get over with the allergic reaction.
And if at all you were to draw up a red list or do not prescribe list of antibiotics, are there any specific array of patients that you think we should be looking out for, where we know that we should stay away, or let's call it minimally prescribed antibiotics?
Basically, for antibiotics, we do not have such type of restrictions too much. But obviously for anti-inflammatories, we have been telling people that people with respiratory illnesses or gastric problems, we don't give NSAIDs. So for them, we give something like a tramadol or just a plain paracetamol or a mefenamic acid. But in antibiotics, if the patient has hepatic issues, or the patient has gastric issues where they are not able to tolerate drugs, then we suggest people that you try to treat without antibiotics. Else, it should not be an issue.
Okay. And endodontic, of course, both Ajay and you also alluded to the fact that uh, very rarely would you need antibiotics. But I'm coming to a point where before they have even seen you, that means let's say they have excruciating localized pain and it has been almost established it's because of endodontic origin or etiology. Do you think at home, when they're taking painkillers, the common phone call that we get is, Dr. Saab, I have taken 3 or 4 painkillers, it's not responding. At that moment in time, the role of an antibiotic you think is important?
Yes, it is very, very important that if we are not able to see the patient or treat the patient, if you're not able to execute the root canal therapy for some reason, either because the dentist has not started practice, or he has started but doing only emergencies like extractions and just prescribing, then if it is a endodontic case, along with the anti-inflammatory, it's most effective if you give antibiotic along with the anti-inflammatory. And maybe if you can plug uh, uh, the cavity with the non-eugenol temporary, because a lot of people put zinc oxide eugenol, which will actually irritate the pulp. So a non-eugenol temporary also has a feature that it expands on setting. So there will be no percolation of oral fluids. Also, non-eugenol temporary can remain in place for at least 3 months. So you're technically buying time. And in case you are sure that it is endodontically, I mean, it is going to require a root canal. So maybe you can put the pulp devitalizer, which I shared in the presentation, either the Pulpex or the Costinerf or the Depulpin. Put the pulp devitalizer, put some bit of cotton on it, or maybe you can crush some amount of Teflon tape, and then put the expanding non-eugenol temporary. We have got three such products in the market. One is by the name Caviton, one is Cavit, and the third one is called Simpat, CIMPAT. So one of the three you can put.
Only a expert clinician like you could seamlessly transit from antibiotics to antibacterials. Fantastic. Santosh Ravindran. So you used to call you Santu. Why are amoxicillin and its derivatives so popular in dental infections? Is there any reason that why they are so preferred?
Amoxicillin has been preferred by clinicians since ages because it has been proven that they work best on most of the bacteria that we encounter in any of the three, that is oral surgery, periodontics, or endodontics. And the combination, that is when you combine it with clavulanic acid, then the efficacy of the amoxicillin increases manifold. Now, only cases where we are unable to manage it exclusively with amoxicillin is mostly in perio and oral surgery, where there may be a lot of anaerobes involved. So then we have to boost it with antimicrobial. Else, the amox covers most of the stuff. In fact, I have been one of the most unpopular dentists in our area because I would stick to plain amoxicillin and I would never prescribe a combination with clavulanic acid, and most of the companies wanted to promote that, and I would stick with this. There are just 3 or 4 of us in a group of 500 in our area who were still with plain amoxicillin. But now the times have changed. Like I said, the new normal is COVID, the virus all around us. So now I've shifted to no amox CV.
Okay, now bouncing back to the endo thing, the commonest thing is a hot tooth, as we normally used to love to call it.
Correct.
And you need a endodontist's dare to go ahead and treat a hot tooth. So what do you recommend a clinician should do to counter a hot tooth? Which antibiotic molecule you think would help?
The antibiotic would continue to remain the same, but what happens is even with Novomox CV and even with the piroxicum, if the patient has taken it even just 2 hours prior to coming onto the dental chair, the hot tooth is still going to trouble you. So how we can counteract that? And that is most commonly happens with the lower molars. So what we do is we inject the patient with Articaine, the one which I showed you, Septanest. And in addition to the block, we also give a long buccal infiltration and a lingual infiltration. Now, this particular technique was shared by Dr. Kandaswamy, a very renowned endo teacher, who had said that there may be cases where the cervical plexus may actually innervate the lower molars, from the lingual side. So we do that. Of course, if you give an intraligamentary, that is the most effective, but you would need to be trained in doing that. So if it is a hot tooth, the antibiotic is not going to help. It has to be the anesthesia that is going to be effective.
Another interesting question is, with so much of, should we say, campaign on amoxicillin, are we developing, or when I say we, I'm talking about patients developing resistance, and should we be looking at a different molecule?
Yes, this is the reason. This is primarily the reason why we were not preferring to give amoxicillin and a clavulanic acid combination right from the beginning. Now, this drug has been doing the rounds since a long time, but we have never prescribed this because there is, I mean, a lot of patients are developing resistance to it, and that is the reason why we should avoid. So I'm talking about this drug basically for the next 6 months at least, not beyond that. After that, endo, we should not be using antibiotics, and as much as possible, keep away from antibiotics and come to a lower antibiotic. Use a plain amoxicillin, regular Noamox, or use cefadroxil in perio, or in oral surgery, you can go ahead with the ciprofloxacin. Try to change the combination so that patients do not develop resistance to it. Yes, definitely. You're absolutely bang on there.
Thank you so much, Dr. Santosh Ravindran. It has been very enlightening. You know, you made such a simple topic, yet an interesting topic of choosing the right antibiotic for different clinical dimensions and disciplines. Thank you so much. You've been so much part of Famdent. I know that I don't need to go beyond just a thank you, but it's always been splendid to have you around. Thank you, Santosh.
Thank you.